I'm so thrilled to introduce this next panel. And I think that really the framing for this is one of the things that Arthur Kleinman said in his incredibly powerful and also great call to action, his presentation in the beginning. He said, we do caregiving. It's basically saying, here I am, I'm here for you. And I think that's what we'll see throughout this panel. These are people who are there. These are people who are there for you. And I want to introduce our panel. We have Shonta Chambers, my friend and colleague Shonta Chambers, who is the Executive Vice President of Health Equity and Community Engagement at Patient Advocate Foundation, and has incredible personal lived experience around cancer. And we'll also talk, around caregiving, sorry. And we'll also talk about looking at caregiving through an equity lens. We have George Dalembert, who's a physician at the Children's Hospital of Philadelphia, and also works as a mentor for residents in his program. And we'll talk about how you really care for the health caregiver, not just the patients, and his role in that. We have Maureen Fagan, who is the Chief Experience Officer at the University of Miami Health System, and she's an awesome nurse and a fellow member of the PCORI panel on engagement, patient engagement. And Maureen will really talk a lot about what they've done over this past year and how they've created sort of professional cohesion and professional community. And we have Cheryl Garfield, who is the lead community health worker she's the lead community health worker at UPenn. Oh my God, I can't believe I lost and Cheryl is a community at Penn Center for Community Health Workers. And what Cheryl does is really a model for how we can bring community health workers into how we can elevate their roles as central to caregiving, care delivery, and caregiving. So I'm going to start each of the panelists off with an individual question, and then we'll see where we go from here. But I want to begin with Shonta. And Shonta, one of the things that is, and another plug for a podcast, because Shonta did the opening podcast of our podcast series with Ashley. But one of the things that was so moving about your podcast and about was about your talking about the elevation of the caregiver, because of the impact, your personal impact and experience of caregiving. And I want to talk to you about two things today. I want to talk to you about both your personal experience and how being, as many of us are, as being in the advocacy world, being a clinical social worker, being a public health worker, how that related to your experience as when you actually had to do personal caregiving. And then we'll go in the next phase to the equity lens.
So thanks, Gwen, and good afternoon, everyone. I think just like anything, right? It all sounds great. It looks good until it arrives at your door and you have to open it up and let it in. And so, as someone who's a social worker by training, so you're talking about someone who's been trained to identify resources and connect people to resources. And as a public health practitioner, someone who understands the dynamics around population health and barriers to healthcare. But when all those things really rest on your front step, is very different when it's your loved one that you're having to care for. For me, it is my mother who has progressive multiple sclerosis, and also my father, who is a now 15 plus year stroke survivor, and as of right now, a 5-month secondary stroke survivor, all consequences of COVID. And so I think when I talk about the elevation of a caregiver, I think it is one role you play when the person you're caring for has some degree of functionality, when they have some degree of being able to be self-sufficient. I think it elevates when all of those things go away. For my mother, for example, my mom is now non-ambulatory. So as my colleague Rebecca pointed out, she can't toilet by herself, she can't walk, she can't even feed herself, unfortunately, due to her tremors. And as a result of that, here is this woman that as a child, I depended on for everything. And now there's this reversal for where she's depending on me for everything. And so, what does that really look like in the context of someone who's seen this play out in so many situations? We see the disparities that are out there in terms of access to care, but now we see the enormous disparities in terms of the resources that are out there to support persons living with chronic and complex conditions. And because of this absence of these resources, caregivers across the country are having to shoulder all of this, and they're shouldering it with nowhere to really turn. In social work, we always talk about pulling out that black file drawer and you're reaching back for resources. There are so many caregivers, including myself, that when I began this elevated journey in caregiving with my parent, when I pulled out that black drawer of resources, there was nothing there. It was no place to turn, no one to call, no one to lean on. So I understand those feelings of wanting to, you don't know if you want to cry or if you want to scream, but you do know that face right in front of you is this situation. It is a situation of an individual, or in my case, two individuals who are relying on you for everything. And the pressures that come along with that. And you're trying to keep this straight face, this game face. And on the inside, you're breaking, you're wearing down, you're emotionally exhausted, you're physically exhausted. And so as my role as a caregiver has changed, the emotional trauma, and that's what I'm going to call it, the emotional trauma associated with caregiving has also elevated. So I just think it's critically important as we have this conversation this afternoon and we leave with these action steps that we really take these to heart, because as Bea just pointed out, caregivers are phenomenal. They are enormous resource, but they're almost like public health many years ago. Public health was one of the most underutilized, understood, and underappreciated resources in our country. Then the pandemic happened, and we realized the value of public health. I don't want it to be something devastating before the value of caregivers is realized. So now's the time for action, because our roles have elevated, but we also need resources to help elevate us, to sustain us, so that we can continue to care for our loved ones.
Yeah, and I think that's such an important point, Shonta. It is, and we talked about it a little bit in all of these presentations. It's been a theme through these presentations, which is both the kind of role of caregiver and what that means to give and receive care, and who was initially the part of that team. What is the economic contribution to this country of unpaid caregivers, and how can we replicate programs like the one that Bea is doing in Washington State to really support and honor that role. We are here for everybody, but that doesn't mean that I think of Arthur Kleinman's metaphor of a rubber band that just was stretched out and left in the sun. And there has to be a way of kind of watering that and bringing it back to, or sort of reviving what is desiccated in the sun. And so part of that is, how do we revive and how do we support caregivers? I think the other thing that you talked about a lot, and one of the things that I find so inspiring and moving when I hear you talk about a lot of your experience over the last, a long time, but particularly over this pandemic year, are the changing roles, and how your roles changed, and how we aren't prepared for some of the roles, and how we really just have to throw out the rules and think creatively. So Maureen Fagan, I'd like to turn to you, and that was one of the things that you really saw as the huge change during COVID in your position as a nurse leader and a nurse executive. And can you talk to us a little bit about what you did and how you made this change? I was really very energized by your notion of creating a safe place for healthcare workers, but also creating a loving relationship among the team?
Thank you. So I think in the very beginning of COVID, without a playbook and a rule book, we were free, if you will, to innovate. And in the innovation, it really brought us together as human beings. And most of the time we were alone. So there wasn't a lot of other folks in the hospital. There were physicians and nurses and CNAs and EVS workers. So there was a cadre of people that became very human with each other and very humanistic. And that really like cultivated the ground, if you will, for us to be able to be very inventive. And so that started it off. And we thought of, understanding about the PPE and doing the pretty much the regimented phenomena that occurred that you heard all around. But what you could see happening was we kept coming back and iterating and as leadership going up on the floors and asking to talk with the families via iPads, or being very creative about how we would engage the families. And so as nursing leadership, we did a lot of daily rounding into the COVID unit and onto the longer term care units where we still had patients, and we're able to connect our patient experience folks with the family caregivers, and then connect to the nurses and the physicians rounding on iPads to people. So we used a lot of technology that was already available, and we're able to connect with loved ones. But then we actually went a step further and said, as we went through rounding, if you as a family caregiver have questions and you might not want the patient to hear them, we had a whole nother second piece where we connected with the loved ones in plain language and asked, what questions do you have about your patient that's here? Do you want to know if they're better, the same, or worse? So we contextualized a lot of the everyday rounding and what was happening with our patients, and then what was happening with our families. But then we also really turned our attention to the staff. And because staff started to come from around the country, there was a point at which we lost a lot of our nurses to travelers. And so they moved around the country, a lot of our ICU folks. And then we got other people's ICU folks, and we recognized, wait a minute, you guys are here from Texas, and we have our staff in Texas from Miami. So we started talking together and being able to connect with staff throughout the country to just say, how are you? Are you still okay? So we got really inventive about things like that, being what I would call the leadership caregiver. So we have this real notion that the work that we do as nursing leaders and as senior leadership is the way that we are role modeling for our nursing and physician staff to do for patients and families. So we want you to feel our love, professionally speaking. We want you to feel what is happening. And when you do that, you are then able to restore and rejuvenate your own self. So there would be many surprises where my team up on the COVID floor would say to me, oh, Maureen, they need ice cream today. I'm like, we'll make ice cream. We'll have it. We'll go get some ice cream. It's not hard to get all these things you're asking for in the moment. We want tacos. So it was very food-based on some days because it's very comforting to have different foods. So, and it was always a surprise, right? So we would come up and we'd make it be a surprise. Well, we realized the nurses started saying to us, the patients are so bored. They really want to do things like color and they want to paint. So not everyone was sick. They were sick, maybe with COVID pneumonia, but they weren't intubated. So we started getting coloring books from people. People would send us things, and the nurses started coloring and the staff started coloring. And it became this very interesting phenomenon of healing their own selves in that way. So while our food services people were always up there with food and then treats, it was great that they actually started to think for themselves, like, let's do other things. And then that rolled over into patients that may have been having cognitive difficulties, but the coloring helped them. So I think it's sort of like you pay it first, and then the creativity that comes from the on-site caregiver is just supersized when that happens.
Yeah, it's such a great story. And the other thing I think you really talked about was that, you know, that caregivers, and in this case they were healthcare providers, really one of the things that you achieved through this was helping people be seen and be known. And we talk about that all the time from a patient perspective, and basically on all of our lives. We want to be seen and we want to be known. And you really created that environment for people where I just that is not always the environment. And if we think about what Arthur Kleinman was talking about in the beginning, and I think it's well documented, a lot of burnout is because of a feeling of alienation. And rather than one of the reasons this story is so wonderful is that rather than feeling alienated by what was going on around you, you used it as an opportunity to create a community. And so that's a wonderful model.
Yeah.
George, I wanted to turn to you because I think, you know, it also fits in with just to sort of tie into what Maureen was talking about. You were dealing with new doctors, and you were dealing with new doctors with two very important, I don't even know, powerful and dislocating sociopolitical realities. The reality of COVID, and then the reality of the country's reckoning with racism. And can you talk a little bit about how you helped and how you were helped by the people that you were mentoring? You're on mute.
Sorry about that. Thank you again for having me today. So as mentioned, it's in my capacity as an associate program director for the residency program, and just as a medical educator, I support the development of trainees at various levels, from medical students to residents to those who are specializing as fellows. And I've had the responsibility and just the tremendous honor, really, of caring for the caregiver. And it's a different type of caregiving role that actually probably still has many of the common threads across caregiving, as well as some of its distinct elements. And I think that if there's been a theme to 2020 and transitioning now into 2021, I think uncertainty would be in the running to be that theme. And that uncertainty hits differently when you're supposed to be the source of answers. And that has really been highlighted in the past year. And in my capacity, I've had to really balance trainees and colleagues feeling the pressure to answer that internal call to serve and that internal call to be there for others, while simultaneously getting cut off from their own support systems. And I am lucky to work with young adults, those who are early in their professional development. It means also that they are at a vulnerable stage in their careers, and I've really had to lean into supporting them during these kind of hectic times. And that means constant pivoting to care for people, to care for individuals as people, and ensuring that they still leave with the level of competence necessary to serve children after graduation, because in so many respects, the world kept moving. And I think that part of what we've been dealing with is just kind of this dual epidemic. And so the reckoning with our history of racism and seeing the effects manifest in COVID rates and in high profile killings, the additional charge that I felt, especially as a Black male pediatrician, has been creating the space and creating the systems to really support my trainees in the midst of the pandemic stress, with the addition of those additional kind of factors, especially for those who are Black, Indigenous, or people of color. And so needless to say, it's hard to be your best self when you're working up to 80 hours a week baseline, but when you add more stresses, people start to reach breaking points. And I think that this year has really highlighted that physicians are people, our humanity has been highlighted. Any narrative that we are superhuman diagnostic machines has really been shattered. And so we've really tried to be intentional about building community in the face of all this disruption, actively embracing physical distancing without that social distancing piece. And with that idea of being known, just really making sure that, especially in a large residency program, we are taking intentional steps to build communities and to build communities within communities, especially when we think about our racially minoritized trainees, to make sure that we are holding space, that we are giving opportunities for people to unburden themselves and to just share a little bit of what they're going through, even though they do have to then potentially put a strong face on it and go back out onto the wards. And luckily I've had a team around me to be able to do this. And I think that just really highlights that there's strength in caregivers coming together and really supporting each other, which I think is part of what makes today's consortium so powerful and so impactful.
Great, thank you, George. And as I was thinking about what you were talking about, where there were multiple things that came to mind, but first of all, I think that there is also in terms of the people who have to have the answers, there's also a change in the way that at least if you have a chronic or serious illness, that you look at your healthcare providers. And so when 25 years ago, when I had my first cancer, if my oncologist didn't know the answer to absolutely everything, I thought that he was an oncologist who was lacking in skill, knowledge. I wondered if I should change. And this, in the breast cancer go around, I actually was comforted by the fact that my oncologist would say, let me look this up and verify the most recent protocols and the most recent guidelines. And we would do it together. We would actually look at the computer together. So I think there has been a bit of a change. I think the other thing that's really that the pandemic has brought out is that that healthcare providers are valued for their healthcare, are much more valued as people, but the healthcare system is much less. The distrust is built even more, and so there's quite an incredible kind of divide between those two things, and I think that's something that I hope we'll be able to bring together in the coming year as we go into the next phase of our lives together as a society. And I think the other thing that you talked about, and my husband's also a social worker, a clinical social worker, but early on, and I forgot this, early on, he and his colleagues would talk about how they had to characterize what was happening as physical distancing, not social distancing. And so with that, which I wanted to ask Cheryl to just kind of put this all in a framework for us about one of the themes throughout this whole policy consortium to date, which is who are the various members of a care and caregiving team. And one of the really incredible movements, I think, and changes in our healthcare system is the integration of lots of different people with different expertise on the care team. And one of the areas where there's been a lot of call for policy work and elevation and valuation are for community health workers who provide an incredibly and invaluable, I wouldn't even say valuable, valuable role in caregiving for people and for families. And I was thinking I would just ask you to jump into a question, but then I realized that I'm not sure everybody knows what a community health worker is. So could you start with telling us what a community health worker is and why they are such an essential part of health and care delivery? What you've been doing is you've been creating a model. The Penn Center is a model for integrating community health workers into the care team. But I think we have to just talk about what can you just tell everybody what it is and why they are so essential?
Yes. Hi, everyone. What I would say is a community health worker is a natural helper, is somebody that possesses a unique quality to address or to assist patients, even their neighbors or family members, with some social determinants that they might have and they need help with. So, as a community health worker, I'm integrated in a medicine team at UPenn. And our team is, I have the attending physicians, I have the residents, I have some med students, the social worker is a part of it, the family members is a part of our team. And where I come in as a community health worker, I sit and I meet with the patients individually or their family members at the hospital. We go over a range of things that they may need once they get home from the hospital. So if I get a patient who may say they going home for the first time on oxygen, but the doctors don't know that this patient doesn't have electricity because they didn't reveal that to that doctor, but they revealed it to you as a community health worker. um, that's where I jump in and go to the team and say, hey, you can't send them home on a CPAP or oxygen machine because they don't have any working electric. So this helps us coordinate, help to get the patient their electricity back on, or see a different place that we can help them go to as opposed to going home. Um, that's one, keeping the patient safe. That's also building trust with the patient so the patient sees that you really are taking the time out to address the needs that they have. Um, Often, sometimes it's not even about what the doctor wants at that particular time. It can always be about what the patient wants to address at that moment. So, as a community health worker, you hear different things. We have those shared lived experiences, as everyone say. But once they are discharged from the hospital, for myself, the doctors, I follow back up with the doctors once they leave the hospital to explain to them what's happened since discharge. And when we're given the discharge document, we are going over that. It's important because patients don't say, they never say they got questions. They say they nod to say, yeah, they understand. And oftentimes they don't understand. So as a community health worker, we're going through that discharge document saying, do you have any questions? Let's jot those questions down for the doctor before you're discharged so you can get a clear understanding as to what they're telling you to do. We're going with them on the first doctor visits to make sure that they have all the documents that they need, any medications, the insurance card, how are they getting to the doctor's appointments, if they don't have transportation, and arranging transportation, and then go with them for that support. So community health workers are, I'm gonna say, a bridge that bridges together those gaps that often are dropped or people don't know or people don't understand. We bring that to the forefront so that the patient can know what they're doing, know what their expectations are to do once they get home, and also bring that support person to go along with them if that's what they need. So it's a range. Community health workers, sometimes they call us community health workers. We can be patient advocates, where it's a different name. It's like almost 200 different names as to what a community health worker is.
Yeah, thank you, Cheryl. And I think the other thing that you brought up that's so important is that patients feel like they can tell you things that they wouldn't necessarily tell their healthcare team because of
Correct.
stigma, because of bias, because of worrying. I mean, worrying that they wouldn't get the healthcare that they deserved if they revealed some of these things. Why? I mean, it is, and I think you provide this bridge that's extraordinary for people to get the equitable quality care that they deserve.
Correct.
And I wanted to bring this back to Shonta because we talked before about, looking at the equity report card and and actually community health workers are very much part of this equity report card. But can you talk a little bit about what that is? I'm asking you to sort of move back into your hat as somebody who's driven to eliminate to create health equity.
So absolutely, Gwen. And actually, before I touch on that, I really want to point out something that Cheryl noted. And I want to make sure it will not be a conversation if I don't address social determinants of health, right? Because I think as a caregiver, what this really did for me, it actually brought front and center the inequities in care delivery. So if I look at my father and what he had access to, when I look at my mother and what she had access to, both of them, when they both unfortunately were diagnosed with COVID, it was a very different experience. And you're talking about two individuals who were living in the same house, but they had two very different healthcare experiences as it relates to how the healthcare system interacted or did not interact with me as a caregiver, or their overall experience. So someone posted in the chat about the isolation, right? Because when people go into a healthcare system, especially a person of color, there's no secret about the historical mistrust for people of color in the healthcare system. So when you begin to put that in the context of the pandemic, right, you're now sending people into a system that they don't trust, with complete isolation from the people that they do trust. And there is not a systematic way for ongoing communication between the patient and their family member. And then you have the family member, that caregiver who's on the outside, and I have to trust everything that the healthcare team is saying to me when they do talk to me. And I'm having to make poorly informed decisions about the care of my loved one. That within itself exposes these enormous inequities that still exist in care delivery. These are all perpetuated by social determinants of health. And as a result of that, as a caregiver, those things that first start with just a patient, they're now front and center in your face, because it used to be a degree of separation because the patient is experiencing the social need gaps that are caused by the social determinant. Now, as a caregiver, you have to understand these social need gaps for the patient, but more importantly, you're also trying to bring resolution to these things. And so for me, that is why when I was asked to chair the NCCN Elevating Cancer Equity Work Group with Dr. Wen, and we started working on this equity report card, I'm coming to all of these experiences in mind. And one of the things that the report card really says, we're not going to move the healthcare delivery system forward if we don't begin to put in measures that relate to actually equity, not equality, but actually equity. And as a part of that and a bedrock of that, one of the key things we called out is the need to address the social determinants of health. That does not mean that we're asking the healthcare delivery system to build this infrastructure. There are community-based organizations out there that we recommend that they align themselves with to help respond to these needs. There are national organizations like our organization, Patient Advocate Foundation, that can help them in assessing and intervening where social need gaps are identified. However, we will not move forward to the benefit for patients or their caregivers if we don't start bringing resolutions to the social need gaps that have been identified through the social determinants of health. And the equity report card provides us a framework to hold systems accountable for addressing equity and not just this concept of equality. Because if we really think about it, there is nothing equitable about healthcare delivery in our country. That's what my caregiving experience showed me.
And absolutely, Lisa Cooper is applauding you in the chat. We'll see Lisa's the video of Lisa and Val later. But it is true, and I think there's we talked. Shonta and I were actually on a webinar yesterday together, and we talked a lot about there's a difference between addressing social needs and addressing the social determinants of health. And one of the things that I think has been so clear to so many more people this past year is what these structural things that we really had to address are. And I think that many of us who've been working in advocacy, and particularly those of us who've had a focus on equity through our years of working, we understood that, but there's something different, something deeper that people are understanding today because they're facing it both in their professional work, as Rebecca Kirsch talked about, but also in what is happening to them in their personal life and their family life. And George, I know I was thinking about how this changes for you in terms of creating kind of meaningful moments that go back to the idea of service that you were talking about, that most doctors go into. They go into medicine for service, and I'm the daughter of a doctor, so as are many people on our team, and that was his drive to go into medicine. He emigrated to the US in order to be able to go to medical school. And so how do you help with creating that sense of community, creating that sense of meaning in what you are doing as physicians, and how can you help not lose that during times of this great stress?
I think that's a great question and observation. I have reviewed hundreds of personal statements for people across the levels, and at their core, they really do all come down to that one thing, like, I want to help people. Mm-hmm. And I think even if you talk to the high school student, the pre-med student, it sticks all the way through, and especially for people who are early in their medical career, who maybe haven't seen as much of the limits in medicine and the shortcomings of our complex systems, running up against challenges, that sense of what's really a personal identity as a servant is trying to be a healer can be especially jarring. And so I think part of what we have been trying to manage is a sense of moral distress, which is the feeling that comes from kind of being unable to carry out what you feel is kind of like ethically appropriate, what's required, really that sense of wanting to give high quality care, wanting to be a healer, and just kind of experiencing that repetitively over time can lead to what's called like moral injury. And that's variably been described as kind of like a deep soul wound that kind of pierces your identity, your kind of like relationships, and that has been very evident kind of like throughout the past year. I think that whether it's in the sense of COVID, where as a pediatric hospital, we weren't seeing as many of the initial cases, but we have an adult hospital right next door. We have some of our trainees who are training in both medicine, so adult medicine as well as pediatrics. And there were people saying like, can we go next door? Can we help in the emergency department? Like, do they have enough PPE for us? We will give up our vacation time. And us having to say like, no, we can't just let everybody go next door. Like, we still have to take care of the people here. But at the same time, trying to hold space for them to understand, to kind of like validate for them, like, yes, we also feel that itch to fulfill those personal kind of drives and that mission. And then kind of on the other side of things, also having people kind of, when there were marches for social justice, wanting to like really get out there and really be a part of that, and like being torn because they had shifts that they had to work. And so I think across this past year, there have been a lot of pulls in various directions that are getting to the core of where people are at. And I think that that's where we've kind of leaned into, is kind of respecting them as people, kind of approaching it in a holistic way, where it's just kind of like not the rules and the kind of like the accreditation requirements. It's really kind of sitting down with people and finding those spaces to have those conversations, to talk about the things that they are seeing, the things that they are feeling. And to at least come to an understanding together, and to troubleshoot kind of other ways to use our voice, to use our stature, to use our position, and to use our privilege to be able to advance things and thinking more broadly about what it means to be able to help, especially as a physician. But that continues to be tweaked, and with every person, it's a different conversation, which is part of the joy of working with trainees, but definitely also one of the challenges.
Yeah, that's great. And the concept of moral distress leading to moral injury is so important, particularly as we look at it within the context of what is happening right now in this country and what we also think is the promise of what could happen in this country. Maureen, how did you deal with, I know this was clearly an issue with you and what was going on you were in Florida. You are in Florida. You are in Florida, which is a very hot spot for COVID, as well as certainly a hot spot for some of the socio-political and challenges that I don't even want to call them challenges, the recognition of how racism has undermined everything that we do. So how did you deal with the moral distress with the people that were part of your group?
So it really cut itself on many different levels. There was the level of the partnership of nursing with the School of Medicine and with physicians in general, and our School of Medicine actually led a protest, and we were very willing to be a part of that and led it on our own campus. So there was the getting together of people to be able to be supportive of each other during the day, all in white coats, making a profound statement to the folks around us. And I think when, there were times when there was rioting that was here. And so, to be able to speak with the security forces and say, wait a minute, like we're protecting ourselves from what, right? Like this is not so much a protection as it in we should be in the street too, right? So there were these conversations that occurred that, we really needed to be able to understand that we can't just be in the hospital. We actually have to be of the community, and the community is hurting right now. And we have to be a force that is in partnership with these folks that are out in the street. So we can't just be in this tower, literal tower is what we call it. We have to be among our peers, and we have to be among the people that live here and be able to be supportive of the people that live here, even in an environment that politically wasn't supportive. So it was a very intense time, because the amount of police that were here was just massive. And as a daughter of a police chief, it was mind-boggling to me that the police were behaving like this. So to me, it was incredibly painful.
Mm-hmm. Yeah. And I don't know what else to say except, yeah, it continues to be incredibly painful. But so I want to ask Cheryl the kind of last question before we go to Q&A, or ask for the last comment. One of the things I was thinking about as you were talking, and I was thinking about what you said, is that community health workers are often the mediators to engender trust with the care team. And the mediators and the translation role is a critical role, but how do we embed that in the system so that that is part of what everybody receives as their care? And how do we not just rely on translators? How are they part of that team and valued as part of that team in order to create equitable care? And I know Penn Center is doing a lot of, it is a model, but I think there's still a significant amount of work to do so that we embed this as part of healthcare that everybody receives.
So for myself, I know at Penn we have a training model, but I myself and a couple other people train third and fourth year medical students. We also train social workers and LPNs on how to be a community health worker. So not only do they take our training, they also shadow a senior or lead community health worker. The times can vary from with the social workers and the LPNs, sometimes it's a week or two. With the med students is either a 2 weeks course or a month course. Recently, because of the rioting, the social injustice, and the racism, we went to our leadership team at Penn Medicine and created what is called a mentoring program so that the CEOs, the CFOs, and other members of the board of directors or the higher um, leadership members can become community health workers. So they agreed to partner with the CHWs to learn more about the role of a CHW and to take on some training so that they'll know how to become a CHW and address it in their daily lives as well. I think integration is very important, and I think that there needs to be whatever organization it is. I believe that hiring a community health worker to be a part of the decision making is very important because we see things and we've experienced things that most people have. It's just like the importance of at one time because I was a part of the committee that did the certifications for Pennsylvania, and they wanted to make it a based off of certifications based off the level of education. And that's a problem because as we all, I don't know if anybody knows, but community health workers have been in existence for, you know, years since the 1800s. And a lot of community health workers lack the educational piece for whatever reason, but it doesn't stop them from becoming a great community health worker and someone we need. I think that um, to stop judging or hiring people based off of their level of education and not experience. Not saying, hey, let's not get them some education. Yes, definitely. But if you have a community health worker, make them a part of those decision makings up front and see how wonderful it becomes because we know the language that most people don't and most patients is going to attract and address and feel more secure with someone that's like them, someone who has experienced the things that they have experienced, and they treat us almost like we're family members because they're willing to open up more than they are to open up to a doctor or social worker.
That is incredible that Penn does you train people to be community health workers up into the CEO level. That's a phenomenal approach. And I think that when we'll put some, I hope we can put some resources and some models. And I know that there is a website that for your program to let people know how they can really create a very, very model program. Patient advocates there was a similar question around credentialing. And just because somebody has academic credentials doesn't mean that they have the skills, the heart, the ability to do what they're being asked to do. And so that model is so beautiful. We have
I say that, I'm sorry, I say that all the time. You can't train empathy. That's something you can't train a person to have.
You can't, and you can't train people. You can help people, give them ideas of how they can see and how they can learn and how they can know. But you have to, but there has to be a base from which they start.
Correct.
So we have about 10 minutes for questions. So I'm going to turn it over to my colleague, Jamie Trotter, who will moderate the questions to the panel.
Thanks, Gwen. So it has been a very dynamic chat. So I'm going to scroll back up My colleague Caitlin Donovan asked the panel if the panel can give us any tips for how to care for a loved one if they're isolated in the hospital, like so many have been throughout the past year. And I know Shonta sort of spoke to when the healthcare team would communicate with her about her parents. So maybe she has some tips, or anyone on the panel, for how to get that communication with loved ones who are being cared for and isolated in the healthcare system.
Jamie, I'll start quickly, and I would say this would have been it's more of a suggestion. This would have been a perfect opportunity to redeploy marketing staff who could have potentially been, again, we talk about this concept of the healthcare team, but we don't really operationalize it. So I think that this would have been a great way to operationalize marketing staff who could really begin to come up with some communication strategies to help keep patients who are in hospitals connected to their families. Because one thing that is at least coming across all health systems is they have someone who's doing marketing, public relations, etc. So use that expertise to help bridge these communication gaps. That's just my recommendation, because I just think that was a missed opportunity.
So one of the areas that we discovered was that many of our patients here use WhatsApp. So they don't use iPads. And so to be able to use WhatsApp and call them on WhatsApp, you could talk to people not even in the United States, which was great. And patients actually were the people that told us that. And then we made that happen quickly with our IT people.
And Jamie, I'll just underscore that again comes back to what I talked about before when we talk about disparities, right? And I'm sure, Maureen, in terms of that, it was because you had access to that technology. When you start looking at some of our other hospitals that may be trauma center or critical access hospitals where they don't have that technology sophistication, what do we do? So we have to begin to think differently in terms of how we help people stay connected. And I think that is one of the learnings for me from this pandemic. You know, the inability to be able to talk with my father for a total of 7 weeks was devastating.
Yes. I think being able to ask the family members how they want to communicate is really what we went to very quickly. So as soon as they were explaining that, IT wasn't doing all the work that they would normally be doing too. So it made it very synergistic to be able to deploy it very quickly. And if they, you know, when they started saying, oh, no, we just were like, no, you have to do this, right? And then you just escalate until they get it. So it was basically, this is coming from the family themselves. So you need to, you need to do this.
Excellent points. I'm looking, we have a comment from Christine Wilson, another colleague. I think this is for the panel or maybe just the audience, I'm not sure. What have you done to care for yourselves in this last year? Anyone wants to share some self-care tips or ideas?
I will.
Okay.
I've been doing yoga, and I started doing planting because I don't have a green thumb at all. So I said, let me try some planting. But also yoga and meditation. So Penn offers yoga via Zoom for all the employees. So I take advantage of that. I decided to go get some potting soil and try planting for the first time to keep my mind fresh, because going out was just absolutely out of the question. And also baking a lot. So I love baking, you know, homemade from scratch. So I've been doing a lot of those things, which is called taking care of myself. Also at the center, we have what is called Do Me Days, where our bosses give us 4 Do Me Days a year. So we don't have to use our vacation, sick, or personal time. It's just time out for ourselves. So I took advantage of my Do Me Day. All because I've been working in so much. I've been doing some policy stuff. I've been doing, working as a community health worker. And got 13 grandkids that's just over whenever they feel like coming over. So it's been a lot, but trying to keep my patients connected to things like cooking shows and working out together via Zoom. So I've been staying really busy trying to maintain and keep myself together in that way.
So reflecting on a couple of things that you've mentioned, one just now and another before, you talked about integrating community health workers into systems overall. But I think that idea of integrating and building systems is really important across many different spheres. So even earlier in the conversation, we talked about social determinants of health, which are really systems level challenges. And every system is designed to get the result that it gets. And so we have to think about what changes are we systematically making to try to change things and to get to where we need to be. And that's for broader policy questions. And I think it's also for things just kind of like wellness. And so for our trainees, for example, we redid our schedule and kind of have built in systematic 2-week spans where they just have lighter rotations. And so that you're not going to do 3 months in a row where you're going from the oncology floor to the intensive care unit to the other intensive care unit and just kind of like setting yourself up for kind of compassion fatigue and just burning out. But like, you know that there is a light at the end of the tunnel. Every 6 weeks, you're gonna have 2 weeks where you just kind of like have a break. You can take a breather, you'll have weekends and you can kind of enjoy yourself. And I think kind of like building things into systems is just so important on kind of across the spectrum. And that's what I've tried to do personally for myself, is just like on weekends now, it's a lot harder to reach me because I'm trying to unplug a little bit. I'm trying to lead by example and might pay for it a little bit on Mondays, but I think it's worth it.
Absolutely. It looks like we probably have time for one more question. So, Melissa Williams, I'd love to hear Cheryl talk more about how they support family caregivers in the communities.
Okay. So yes, like I said, we support the whole total family. So like a lot of stuff that now I'm gonna talk about a case pre-COVID to now COVID. Pre-COVID, we were going to the patients' homes and working with the families one-on-one together. With assisting them like on rental assistance, on utility assistance, making sure that they might want to have some therapy classes, because it's a lot when you have one caregiver taking care of everything at one time. So we try to make sure we're training the family members just like we would be trained, like we're being trained on how to support the patient and not be burned out with offering them some therapy for themselves as well. And then making sure that they take some time to themselves and not feel bad about taking some time to get the mental health that they need for themselves so they can continue to care for their families. So now that we're in COVID, everything is done virtually from home. And we still assist with those things like utility assistance and home repairs. Recently, I have a patient who basically lives in the basement. She's elderly, so she's older. She lives in the basement and her family can't get to her. So I jumped in immediately and helped the daughter get in touch with the director of housing for getting her transferred to a new floor. So we take our patients, family members by the hand, care for them just as if we was caring for a patient, and walk them through those steps that they need so that they can still not only be healthy for themselves, but still be able to provide services and assistance to their loved ones. So whatever they need us to do, that's what we do.